Today we'll be discussing the advantages of arteriovenous grafts over arteriovenous fistulae for hemodialysis patients undergoing dialysis. So, what does this mean? We're talking about chronic kidney disease, which is a condition that 1 out of every 10 American adults have some progression of, and end-stage renal disease is the advanced stage of this condition in which the kidneys cannot filter waste and excess fluids from the blood. And there are 2 primary treatment options for end-stage renal disease: kidney transplants and dialysis. As this image on the right shows, dialysis is the preferred method, and that is because kidney transplants pose a risk of rejection from the donor, and also there is an organ shortage. So what is dialysis? Dialysis is the rapid removal and filtering of blood through a dialyzer coming out of your artery, going through the dialyzer, filtering, and then returning back to your body into the vein. This image shows direct access, but this is not preferred because it does not provide the large amounts of flow needed for dialysis, which is approximately 1,000 milliliters a minute, and there are durability concerns of continually sticking arteries and veins with needles. The immediate solution is to use a central venous catheter as shown here, and they're immediately used because they can be rapidly placed and they provide immediate dialysis access, but they are not ideal long-term solutions because there's a high risk and severity of infection, which can result in sepsis and potentially death. They can also result in damage to the thoracic architecture, as shown here, due to the high flow rates associated with dialysis, and the catheters must be replaced frequently due to clotting, infection, and dislodgement. Additionally, catheters also reduce the quality of life of patients. Patients must keep their catheter access dry, so this can make bathing very difficult for patients with these accesses. So long-term hemodialysis methods include fistulae, as shown here, and grafts. A fistula is a direct connection of an artery to a vein via an anastomosis, and a graft is a biological or synthetic conduit between an artery and vein. The current paradigm suggests that arteriovenous fistula is the preferred method, while arteriovenous grafts are not the preferred method. However, there are plenty of problems associated with fistula usage. One of the primary failure modes for fistulae is with maturation. Maturation refers to the arterialization of a vein in which the venous wall is thickened to withstand higher pressures required for dialysis. And this maturation is required for fistula use. This image on the right highlights an artery in a vein and then a fistula forming, and the successful fistula forming from enough blood flow being diverted into the vein, while on the right there's not enough blood flow being diverted into the vein here, which is unsuccessful, or stenosis occurring where there is still not enough blood flow. Fistulae can take anywhere between 4 weeks and 12 months to mature, while some never fully mature. Additionally, there is no reliable method to determine the time it takes a fistula to mature before implementation. Thus, a central venous catheter must be used while awaiting fistula maturation. So this image shows the stenosis that can occur in a fistula that failed to mature, and this happens from not enough flow getting through there, and the shear stress, which is low, results in the diameter shrinking, making it harder for access for dialysis. So there are plenty of other problems associated with fistulae too, including lymphedema, infection, aneurysm, stenosis, congestive heart failure, Steele syndrome, ischemic neuropathy, and thrombosis. Additionally, if a dialysis needle is inserted into a vein too many times, the vein can be scarred and destroyed, which will then destroy the fistula. Due to these problems, costly and frequent interventions are required. Fistulae on average require 3 to 4 surgical interventions that cost anywhere between $600 and $21,000 per intervention. And all these interventions are required before the fistula can even be used. So grafts pose some advantages over fistulae, one of which is the maturation time is consistent at 2 to 4 weeks, and the shorter maturation time compared to the 4 weeks to 12 months means that the patient will use the central venous catheter less than if they were to use a fistula. They also require fewer interventions during the maturation period at 1 to 2 compared to fistula, which needs 3 to 4 surgical interventions. And less interventions results in less stress for patients and less of a financial burden. Fistulae also create turbulent flow, while grafts can be placed in a loop configuration to prevent turbulent flow. So this image here shows a computational model of a fistula in which the blood must take a sharp corner through here, which results in this turbulence to form, And turbulence results in thrombosis or blood clotting, which can reduce flow in hemodialysis, or it can embolize and cause blockage. These grafts can have multiple configurations, so with this loop configuration, the blood will flow straight through and come right back out, whereas with the fistula, it has to go through here and then take this sharp corner. And a graft can also have this straight configuration, like so. So there's greater opportunity for innovation in grafts versus fistulae. You can use different materials and new configurations to be developed for grafts, while fistulae just rely on the native anatomy. In conclusion, these advantages, coupled with the opportunity for innovation, support the funding and implementation of grafts over fistulae.